So our next speaker is Sarah Keys, who's a PGY2, is that right? Yes, with another sickle cell presenter today. I'm working with Haley Merkley. So welcome, Sarah.
Hi, everyone. Thank you so much for having me again. My name is Sarah. I'm one of the second-year internal medicine residents at UBC, and I'm very delighted to be presenting our project, Delays in Hydroxyurea Initiation for Patients with Sickle Cell Disease, new to British Columbia. I had the opportunity to work with an incredible group, including my supervisor and mentor, Dr. Merkley, who's here today. So with that, I'll get started, and kind of great timing in terms of presentation. So there's already been a bit of background, but again, just to overview, sickle cell disease is a herited hemoglobinopathy of abnormal hemoglobin S polymerization. And so the sickled hemoglobin S cells polymerize, and this causes chronic hemolysis, vaso-occlusion, and progressive end organ dysfunction. Ultimately, together, this reduces life expectancy, reduces quality of life, and so the primary mainstay disease-modifying therapy is hydroxyurea. This is a medication that induces fetal hemoglobin F, and so with increasing fetal hemoglobin F, this dilutes hemoglobin S, prevents further polymerization, and overall reduces complications, improves overall survival. The key is that early initiation is important for these patients. The issue that we're facing in BC is that, unfortunately, despite hydroxyurea being first-line therapy for sickle cell disease, it is unfortunately off-label in BC. So many patients face significant delays in medication access. In terms of options, patients can potentially pay for the medication privately, although this can be cost prohibitive for some. Alternatively, patients can opt into pharmacare, which is our provincial deductible-based medication coverage program, although this has its own challenges because patients have to submit their income tax return for the prior 2 years, and their specialist also has to apply for special authority medication coverage, which is even more paperwork. So, together, patients often face delays, and the goal of this project was really to characterize that, better understand the cause and consequences of delayed hydroxyurea initiation. And so to do this, we identified all adult patients with sickle cell disease, regardless of genotype, who were new to the Adult Red Cell Disorder Program of BC out of St. Paul's Hospital between January of 2022 and February of 2025. And we retrospectively reviewed their charts for baseline patient information, disease characteristics, first hydroxyurea use in BC, as well as reasons for delay if present, and then sickle cell disease-related morbidity and mortality. We primarily applied descriptive analyses, but used negative binomial regression to compare total complications between delay versus no delay groups. And so these were our results. We included 56 patients in the review. Median age at time of relocation to BC was 25 years old. You can see general characteristics, so around 60% were female, around 80% were of African geographic origin, about 10% were refugees. In terms of genotype, around 75% had hemoglobin SS disease and 21% had hemoglobin SC. And around 95% had a prior SCD-related complication, primarily prior vaso-occlusive crises, but again, second most common was acute chest syndrome, which is a leading cause of morbidity and mortality among these patients. Interestingly, about half of these patients had had prior hydroxyurea use before coming to BC. However, of the patients with prior use, around half of these patients discontinued upon relocation, primarily due to access issues. And so ultimately, among the patients, around 3/4 ultimately did use hydroxyurea in BC. However, 2/3 of these patients had a delayed initiation. And you can see that the median time from time to relocation in BC to first hydroxyurea use was 13 months, so over a year. And to kind of better understand the morbidity associated with this delay, so among the patients who did end up using hydroxyurea but had a delayed start, around 65% of these had an SCD-related complication before their start. and this included 51 vaso-occlusive crises requiring healthcare contact. This excluded crises managed at home, 12 acute chest syndrome, 8 others. This was AVM, ocular abnormalities requiring intervention and whatnot. This led to 14 emergency department visits, 40 hospital admissions with a median length of stay of 4 days, 58 units of red cells transfused, and unfortunately 1 mortality that was related to out-of-hospital cardiac arrest of unclear etiology. To better understand the reasons for delay, we found that around 40% of cases were associated with delays in hematology referrals, largely due to kind of gaps in care in primary care. And then around 30% of cases were associated with delays in medication coverage, and this was kind of the process that I was explaining in terms of challenges with applying to pharmacare for coverage. Ultimately, we found that hydroxyurea delay was associated with an approximately 4-fold total increase in SCD-related complications compared to no delay. And breaking down kind of a cost analysis of this, so for the 27 patients that had a delayed start over the medium kind of time frame of delay of 13 months, the cost of the medication over this time period would have been around $35,000, whereas the approximate cost of the healthcare utilization for all of the complications that these patients unfortunately sustained was close to $400,000, which is a gross underestimate because this only included certain healthcare costs that we were able to calculate. It excluded investigations and additional treatments. And so overall, our take-home was that delayed hydroxyurea is common among patients with sickle cell disease new to British Columbia, primarily due to referral lags to hematologists with specialist care in this area, as well as barriers in obtaining medication coverage. High rates, these delays lead to high rates of potentially avoidable complications, and although our study did have some limitations with a low sample size and whatnot, we do quite strongly feel that efforts should be made to increase access to this medication, primarily by addressing system level barriers. So with that, happy to answer any questions.
So that's very interesting. It's great. So how are you going to improve the access by addressing system-level barriers? What are those system-level barriers? How do you get by those?
So I think that's a very big question and obviously an incredible challenge. And different provinces have done different things. I think, I don't want to speak out of turn, but my understanding is there has been some talks with kind of political advocacy groups to try and increase medication access. And one route is to try and decrease the barriers to hydroxyurea coverage. So for example, it's currently a class 1 indication for oncologic indication. So if you have a cancer diagnosis for which hydroxyurea can be used, there's basically no cost to the patient and it's easy to access. But we don't see that parallel for sickle cell disease. So I think one step could be basically decreasing that, that barrier in terms of the indication.
How do we get them quicker to the doctor?
Pardon?
How do we get them faster to the appropriate doctor?
Yeah, that's also a great question. One obvious barrier is lack of primary care physicians, which, I think there's a lot of changes that are happening in BC right now in terms of even kind of at the medical school level, opening up a new medical school to try and increase the number of family physicians in the province, although that is a kind of long-term solution. I think making it easier to refer patients, and we see more nurse practitioners and whatnot, making it easier to refer to hemoglobinopathy clinics is one route. Yeah, it's a challenge. Oh. Self-referral, thank you. Thanks.